So, Dr. Aslie, thank you so much for joining me.
Thank you for having me.
It's an absolute pleasure. Could you kick us off and tell
Please,
us a bit about your background and what you do today?
yes. My name is Ardavan Aslie. I'm an orthopedically trained spine surgeon. That means I did my training residency in orthopedic surgery, and then I did a year of fellowship in spine surgery. And I have a fully spinal surgery practice in Sacramento, California. I went to undergrad in UC Berkeley. I double majored in physiology and genetics. Then I did the medical school in New York Medical College. Did my residency in orthopedic surgery in the St. Vincent's Hospital in New York City. And then I did my fellowship in Boston in part of Harvard University, which was at a hospital called um, Beth Israel Deaconess Hospital. And after that, I moved back to California to where my family is, close to where my family is, which is Sacramento, California. And I've been practicing in Sacramento for the last 20 years now.
Wonderful, wonderful. So you never at any point thought spinal surgery is not for me. You stayed with it.
Oh no, just actually opposite of that. I always tell people that I somehow, and I didn't really plan on it, somehow I fell into a job that I was born to do. It just happens that it's a field that I felt really comfortable, and I love it. I mean, everything that I do, I just intrigues me, and I keep going.
Mm.
And that was one of the more important reasons that I end up here with the research and development or so.
Mm. I mean, I've heard you speaking on podcasts before, and what comes across is that you do have an incredible care for your patients. You care about the outcomes. You care about what you're doing. Hence why you've changed your sort of ethos as time's gone on. And I want to hear a little bit more about that. But can you just lay the ground for us around spinal surgery? Like, why do people get spinal surgery, and what are the different types of spinal surgery?
Sure. Um, Spine surgery is a major undertaking in somebody's life because you have only one spine. Uh, a spinal pain, a back pain, neck pain can affect every aspect of your life, your marriage, your sleep, your mood. You become a different person when you're suffering from pain. So, and this happens to be very common. So it's a very important condition in the society that affects great majority of people in neck and lower back pain. When somebody suffers from neck and lower back pain, the first thing that we do is try what we call non-operative treatment. So as a spine surgeon, I always tell my patients, my job as a surgeon is to do whatever I can for you not to end up in surgery. Uh, the way I explain to my patients is that normally treatment of neck and back pain falls into three stages. The first stage is what we call manipulative treatments. The whole idea is to manipulate the body with one technique or the other and try to get them better. In that category, you have chiropractic care, physical therapy, massage, yoga. It's a whole world.
Mm.
Second stage are what we call therapeutic procedures. And most of them are steroid injections, the most common ones. And then the last and third step is surgery. Now, when it comes to the steroid injections, I have to explain why we do those. Neck and back pain happens because most of the time there's a damage to a disc. Now, spine is a bunch of
But
bones that
hang
are
on,
stacked up.
I'm gonna jump in there because, and I'm gonna
Sure,
sorry to cut you off when I've asked the question, but
sure.
I'm gonna tell you a little bit around my perspective here, so that
Mhm.
you know the angle that I'm coming from. So when I was 18, I had bulging discs, and I had a surgeon who said, he wanted to go in and he wanted to do a discectomy, and he wanted to and I still had very bad back pain, and I ended up actually healing all of it through strength training, and I've had no
Wow.
pain ever since. And so that's my and I know everyone, depending on their experience, has a different view on this. So, like, in terms of the non-operative treatments and their successes,
Mhm.
it seems like there's a huge focus on just chiropractic, and then, oh, that doesn't work, let's go to injections and therapy. So when you said there that the primary reason for pain is around the discs, from my view, it seems like there's a huge muscular issue as well. Is that not factored in?
That's an interesting question that you're asking, and that's the question that's been in our heads, in our goals, throughout the spine surgery. Um, well, let me explain to you a little bit of anatomy so we can go back to that question. Spine is a bunch of bones stacked up on top of each other. They're separated by these cartilage, we call them disc. Then you have the joints in the back, we call them facet joints. They're the moving joints that connects to each other, like a shingles on the rooftop in the back. Then you got all these muscles, and the muscles are very complex. What we call paraspinal muscles are very complex array of muscles going in different directions because they have to do a very complex job, which is moving the trunk in a three-dimensional space, basically, and stabilizing. So there are a lot of moving parts to the spine. And of course, the biggest understanding is that if there's a lot of moving parts, therefore, there's a lot of things that can break down. So the whole thing about back pain and neck pain is to figure out where the pain is coming from. So as you said, you're right. The first thing you're going to think, well, if it is the disc, is it the muscle, is it the nerve? To be truthfully honest, we don't know. We just don't know where the pain starts, what happens, where does it go, why it happens, because there's a lot of unknowns. And the first thing that I explain to my patients in my book is that spine surgery is a very young field. We really couldn't see these discs or anything in spine till the invention of MRI. Now, MRI was the first imaging study that showed us how the discs or other structures look like. And MRIs were not invented, became available till 1985. Well, the first MRIs, they were not good quality. And of course, when a test becomes available, it doesn't become available everywhere. So let's say took another 10 years to get a better MRI, the quality that you can see, and then become available throughout the country or throughout the world. So we're talking about 1995 till now. That gives us only 25 years of trying to understand a very complex problem of where the pain is coming from.
So short.
Right, so short. We're just beginning to kind of understand. Now, I've gone back and forth in this, and there's no scientific study, there's no scientific proof. I initially, when I started my practice, I thought that, whoa, there's so many things going on, so many things can go wrong, and we can only pick up the parts that are actually caused by the disc that we can see in the MRI. And if it's a muscle, if it's a sprained or strained muscle, we're not going to be able to see it. And let me tell you, what I'm about to say, I might change. So I'm just saying it based on just kind of a feeling. There's no scientific answer to that. After 20 years of practice, I'm leaning back more toward disc being the major contributor to the neck and back pain.
Interesting. And I just want to query in there, and we're going to get into some of the more nuanced areas of the book, which I think is fascinating as well. But because there's many people who have bulging discs that you can see on an MRI scan that do not present pain. And then you have many people that do present pain. So it seems like the bulging of the disc or the disc tear doesn't presuppose pain.
Absolutely. And that's the first thing you learn as a spine surgeon. And that creates a big problem to the spine surgeons in terms of treating our patients. And I'm going to explain it to you. And that's one of the things I really think that spine surgeons we haven't done ourselves a favor in terms of educating the public in terms of what we can, what we cannot do. So they would understand and have a realistic expectation of a surgery. And that's one thing that I've tried to do with my book. I didn't want to just write a book and complain about the affairs of spine surgery. I wanted to be an educational book so I can teach what I've learned in 20 years to my patients. And you are absolutely right. Why? The way I explained is that it's not the damage that causes the pain. It's the inflammation that causes the pain. And inflammation is body's attempt to repair the damage. And that's why you have good days and bad days. The damage doesn't change, But you have a good day, you do something, and then that area is inflamed, and now you have a bad day. And that's why what I'm about to say is very important. There is no correlation between how a disc looks and how much pain it generates, because it's a very common question that when the patient comes to my office, they want to know two things: how bad is their situation, or basically what's going to happen to them. And I have to tell them, sorry. First, there is no correlation between how bad the disc looks and how you feel. I have patients that they have a horrible looking disc, they're worn out, bone touching bone, and they're like, I'm fine. I had some pain. I did some physical therapy. And by the time I made the appointment, I was in pain, but now actually I'm better. My pain is gone.
So who decided to start working on the discs then?
I'm sorry, say that again.
But who decided to start working on the discs then, if like there's no real big correlation?
You mean in terms of the surgery?
Yeah. So where did this
Correct.
sort of thought process come from that we should work on the discs if
Correct.
there's no correlation between the pain?
Correct. It all comes from the patient. Patient is the only person that they know how much pain they're in or how much they can tolerate. So we have learned that the disc, a herniated disc, can cause pain by two ways. One, it can itself can cause pain because it's injured, or two, with the bulge, it can press on a nerve and cause that nerve to start becoming painful, which shows itself as a pain, radiating pain into distribution of that nerve. So everything gets dictated by how much pain the patient is having. So let's say you get an MRI, the patient says, I have pain going down my right leg. You get an MRI, you have a disc that's injured, and you have a herniation on that side. Let's say the pain is on the right side and the herniation is toward the right side. Then you have a correlation between the patient's complaint and what you see in the MRI. Therefore, that disc is more likely than not causing that pain. So in that situation, you try whatever you can to help the patient and let the pain go away by therapy and injection. If that doesn't happen, then patient, not the doctor, patient needs to make a decision. Do I want to go ahead with surgery? Is my pain bad enough that I want to take that chance and proceed with surgery? I always tell my patients, as surgeons, our job is to tell the patients if we can help them or not. That's it. Should I do surgery? Should I not do surgery? It's the patient's decision.
Okay.
So if the patient has a lot of pain, they can say, you know what, I have pain. I did the injection. I didn't get better. I have therapy, but I can live with this. I don't want to go through surgery. I don't want somebody cutting on me. Then that's fine. And they can go on. And then, of course, the other thing is that why we don't recommend surgery, because we don't know what's going to happen to the patient. Some patients get better. And it all depends on how long you've had the pain. Let's say you've had the pain more than a year, then your chance of getting better without surgery is low. But if the pain, you've had it for 2-3 months, there's a very good chance of that pain getting better with therapy or injections or so. So let's say the pain is, let's say 3 or 4 on a scale of 10, which is very difficult to gauge the pain. But let's say 3 to 4, so not horrible pain, but moderate pain. Then this patient can go on for a long time with that pain, and they have a poor quality of life, but it's not bad enough to push him towards surgery. But let's say a patient comes in and says, I can't live like this. I feel like I have a knife stuck in my back. I feel like somebody burning my leg. Basically, you have a torch against my skin on my leg. If that's true, then this patient cannot even tolerate a month of pain. In that situation, you do an injection. If that works great, if it doesn't, patients will tell you, it's like, I can't live like this. Take me to surgery. Then you book them on surgery and you do the surgery, and that normally is a very successful surgery.
Yeah. I understand. It must be quite intense when you have someone coming in telling you that they're in incredible amounts of pain, and they think that I guess in many cases you do have the answer in some of the methods that you use, but they think in their head, they know that you've got the keys to the kingdom of a pain-free life. And so therefore they just say, doc, give it to me. Come on.
Correct. Yes. And that's the problem. Yes and no. See, only thing that we have for us available is an MRI. Now, we already said that there's no correlation between a bad disc and pain. So in a way, we don't have a test that will tell us where the pain is coming from. We don't have that. We got to go by our intuition, training, and of course, what's happening on the MRI. Now, I divide my patients into two categories, simple and complex. Simple if they have one or two discs that are bad, complex if they have three or more. So why that's important? Well, because if they have three or more discs that are bad, I cannot look at those MRIs and say which one is the disc, which one of these discs is the one that's hurting you. So that's the problem. I tell you an example. I had a patient about 9 years ago. A nurse at our hospital came to me and said she had severe neck pain and arm pain, and she couldn't live like this. She had tried therapy and injections. She wanted to see if I could help her. And I saw a bad disc, a damaged disc between C5 and C6 in the neck. And I told her, yes, I can help you. Sure, let's do the surgery. I can remove that disc, put a block, fuse the two vertebrae between 5 and 6, and that has a chance, about 80 to 90% chance of helping you. And that's based on our experience. Well, I did the surgery and she didn't get better. And I was like, oh my God, what do I do now? And she was a nurse at our hospital. I myself sent her to about 2 or 3 spine surgeons that I knew in town, and they all said the same thing. Said, Dr. Aslie did the right surgery. You're not better. Sorry, we don't know what to do. Sorry, this is it. So and she stuck with me. After a year of doing all sorts of other tests, I told her, I said, there's another disc below C5-6 at the C6, C7. And it doesn't look bad at all, but there's a one small tiny tear in there. It could be that, but I cannot talk about another surgery. If I do that surgery, you're not better, I can't forgive myself. And now you have 2 surgery and you're still not better. But it could be that. You need to make that decision. So she came back to me and said, I can't live like this. I'm going to take my chances. So I did the surgery at the level below C6 and C7, and all the pain went away completely.
Wow.
So that is a very good, and that's why sometimes spine surgery gets a bad rep, because, when we do surgeries, we don't want to just go in and do surgery on everything. Like 5 level, 3 level, just kind of like what I call a shotgun surgery. So we want to do least number of smallest surgery with the biggest gain. So we tend to operate on the worst looking discs. Well, it turns out that sometimes the worst looking disc is not the source of the pain. It's not inflamed. And the one next to it that doesn't look bad at all, that's what's killing the patient. And that's sometimes why we do the surgery. And this is the problem. When you do the surgery, patients sleep. They cannot tell you that, oh, doc, you got it. Okay, that's it. They can't, you don't know. So I tell my patient, I said, every surgery I've done in my career, and I've done more than 4,000 surgeries, I walk in the next day with my fingers crossed.
Yeah.
And I ask them, did it work? Did it not work? And thank God I have a very good experience. But I do have patients that surgery didn't work for them. There are not many, but I do have, any surgeon has that, because that's just, unfortunately, that's what we have to deal with.
Yeah.
And in those surgeons, I have to start all over again.
Yeah, I bet it's incredibly difficult. I mean, the angle that I see, because I'm usually one of those people who says who has a bad idea of spinal surgery because of the industry that I've been in. And I'm a strength coach, I'm a personal trainer, I'm a nutritionist, and I see so many people in pain, general body aches, pains, because they sit at a desk all day. They are really weak in their glutes and their hamstrings, and they're really tight in much of the musculature in their posterior chain. And I've had clients come into me and they've either worked with a physio before, or they've said, look, I can't get rid of this pain. So-and-so recommended you come to me. And we work on their glute strength and their hamstring length and strength. And we work on their lower back stiffness. And thoracic mobility. And 9 times out of 10, if not 10 times out of 10, that clears up the pain. We also work on the nutrition aspect. We also work on this inflammation side of things that removing ultra processed food, removing like junk in the diet that's making people inflamed and ill, and making them sleep better, and going for the holistic approach, which nearly always clears up these aches and body pains. Now, I'm not stupid enough to think that that's the only way and that works for everyone. However, I do have an idea that there are many people who get unnecessary surgeries out there.
Correct. This is what I tell my patients. My patients come to me all the time, and I'm talking about every day. There's a technique. There is something that I heard. Somebody recommended something. They ask me, do you believe in this? I tell my patients, this is a standard talk that I tell all my patients. I said, I believe in everything, as long as it's not super expensive. I believe in everything. You try it, you're better. That's all we care. We just want you to get better. You try that you're better, we're good. You try, you didn't get better, then we have to go to the next step. You can go as far as you want to go. You can try whatever. You say, hey, can I try this? Can I try that? I'm like, absolutely, try it. And basically, it comes down to a point that if that patient gets better, we're all good. You're happy, I'm happy, everybody's happy. If you're not better, then you can try different therapy modalities. And if at some point patient decides that, look, I can't do this anymore, I can't take this anymore, I want to give surgery a chance, because you're right. We, as surgeons, we cannot guarantee a perfect outcome. That's why we don't recommend. Our job is not to recommend surgery. Our job is to sit back and tell the patients, these are the situation, these are your chances of getting better or not getting better. And a lot of my patients tell me, they say, we heard our friend said, or relatives said that if the surgeon talks about surgery, just don't accept it because it's not going to work. And I tell them, no, you don't understand. I am telling you the best thing is not to do surgery. I am the one telling you that the best thing is not to do surgery. But if the patient is sitting in your office crying, saying that they cannot get sleep night after night after night, and they say they want to proceed with surgery. Some of my patients, they tell me, Dr. Aslie, if you tell me that I have a 15% chance of getting better, I'm going to take that choice.
Whoa. But he's saying 15% there, like that's 15% you remove the pain, or what's the 85% chance if it goes wrong? Is that paralysis? Is that
no? That I just said that as a
as an example. No, I understand, right. But what's the worst case? I mean, like, it's just that the pain doesn't disappear, or like,
right. I don't remember. I cannot say no, because nobody can say no. It's possible that I've met somebody that worse with surgery, but I doubt it. I tell my patients, that's one thing you don't have to worry about getting worse. I mean, don't get me wrong. I have patients that they have one simple injection, and when you put a needle, you don't know where the needle tip is going. If it tickles the nerve, after a simple injection, they can get these nerve pain that they didn't have before. So unfortunately, spine is a very tricky area. So there are, but chances of getting worse with surgery is low. But absolutely, those are one of the things I tell my patients. You can get worse, you can have a nerve damage. When you do spinal surgery, when you try to go to those discs, do a discectomy, remove the disc that's extruded into the canal, you have to move the nerves out of the way. Well, moving out of the way, that means stretching them, basically. So, and as you stretch them, the patient cannot tell you, like, whoa, wait, you're about to do this. So patients sleep. And then it's not till they wake up and say, wait a minute, I have this numbness I didn't have before. I cannot move my toe now. And thank God has never happened to me. But it can happen. And I hear every time I go to conferences, there are cases that gets presented that, these things went bad. And that's why those are the things that you explain to your patients, that it can happen. And that's based on those, they make the decision. Some of my patients say, well, now that you told me that I can have a nerve, I don't want that surgery. And that's perfectly fine. But this is the situation. My patients that they want me to do surgery on them, they don't get scared, because they're in so much pain that they don't care. They said, you know what, even if you tell me I'm going to get paralyzed, I don't care. The way I don't have a life right now. just just do the surgery. I need that surgery. I need something.
Mm. Mm.
You know.
Yeah, I understand. Well, this is the option that you offer. Like I understand
Right.
that's your
Now,
predicament. So
now I need to explain something. There are surgeons and there are surgeons. I'm not saying that all of us are like that. This is me. This is how I practice my surgery. I'm busy enough that I can keep my practice busy and just pick and choose the people that, they totally, absolutely need the surgery. Like they've made up their mind that that's what they want. And that's one of the reasons I've never been sued ever for any surgeries I've ever done. But I cannot say that about my other colleagues. There is possibility that some other colleagues, they want to tell the patient, hey, why do you want to suffer with this? I can help you, and then maybe promote the surgery.
is it
I don't want to
quite
say
common for surgeons to get sued?
very common. Yeah, absolutely. This is a very dangerous business. What we're doing, we're dealing with nerves. I mean that we're manipulating nerves, stretching them, pushing them, yanking them, putting the screws. When we put screws in or doing something, we're putting those screws millimeters away from nerves.
Yeah.
So it's and not only that, when you approach the spine, well, in front of the spine, you got all these big veins and big vessels, aorta, vena cava, and those are all very dangerous structures. So you have to get them out of the way. So it's you're inside all these dangerous stuff. So bad things can happen, and I've heard happening. So it's very spine surgery is very challenging.
I bet it is. I bet it is. I don't envy you. I have to say I don't envy you. But I'm curious, can you just lay out for us the sort of overarching different types of spinal surgery? From my idea, the sort of disc work and then the sort of fusion side of things. I mean, could you enlighten me there?
Or overall, now I'm super simplifying. What I learned in my practice is that spine surgery can get so complex that you just get lost. You just can't make a decision. I learned that in that situation, you have to simplify it. Otherwise, you can't come up with a decision. So overall, there are two types of surgery in spine surgery. One we call the laminectomy and discectomy, and one we call the fusion. And it all comes down to where the pain is coming from. If you have a disc bulge pinching on a nerve, and this patient is having leg pain, what we call extremity pain, like an arm pain or the leg pain, well, we know that if you go in and decompress that nerve, remove that piece that's extruded, that would help the patient. So we call that discectomy surgery, laminectomy, discectomy. Laminectomy because you have to remove part of the lamina, which is the roof of the canal. And then discectomy, you take that piece out. And so that's a very simple surgery. Results are very good. I mean, 90+%. And the return to function is extremely good. Now, the other problem is if the patient is having what we call axial pain, neck or low back pain. In this situation, it's not just the pinched nerve, it's actually the disc itself is hurting the patient. In that situation, the only way to fix that, of course, after exhausting all the non-operative care, is to go in, remove that disc, put a spacer where the disc was before, put a spacer, and turn the two bones into one bone. And that's the fusion surgery. So to summarize it, two types of surgery. For arm and leg pain, we do laminectomy. For neck and low back pain, we do fusion surgery.
Okay. And this sort of the spacer that you're putting in there, what's that made of?
It could be different things. It could be a titanium cage, could be a what we call piece of plastic. We call it PEEK, P-E-E-K, polyethylene, ethylene glycol, something like that. It's a piece of a special type of plastic. Okay. PEEK, or it could be bone. It could be cadaver bone.
It's very interesting. I mean, because the thoughts I have of sort of spinal fusion is when you sort of see the quite graphic sort of X-ray image or MRI image where you can see sort of screws flying everywhere and different rods going everywhere. So, I mean, are there different levels of spinal fusion whereby you have like very basic small spinal fusion and then you have quite extreme, multiple disc fusion?
Correct. And there are two, overall, there are two parts, two subspecialty of spinal surgery. One is what we call deformity surgery. In deformity surgery, patient has scoliosis. The whole spine actually twisted on itself. In that situation, you're talking about long spans of fusion to derotate the spine and try to regain the original alignment. That's a deformity surgery. When it comes, and that's only 10% of the spine surgeries that are being performed, so a very small number. The 90% of spine surgeries that are being performed is a surgery that's been done to treat pain. Well, when you have pain, pain normally happens in a localized, there's one area that's, giving the patient grief. Now, I just can't imagine 2-3 area hurting at the same time, statistically speaking. So normally and it mostly comes down to one disc that's causing the problem. Now, here comes the problem. I pointed out earlier. If you have 1 or 2 discs that are bad, rest looks good, then that's an easy surgery. You do a 1 or 2 level fusion, and these are the patients that they do very well. The results are very good. Return to function is very good because when you fuse 1 or 2 levels, it doesn't really affect the overall biomechanics of the spine. The damage to the spine is low, and they do very well. But now, if you have a patient that has an MRI, in the MRI they have 3 or more discs that are not good, then here becomes a problem. Well, which one is the one that's hurting the patient? There's no really way to know that. So if the patient comes in, they're in a lot of pain, and currently the current practice is that if they have 4 discs that looks bad, you do a 4-level fusion. If 5 discs that looks bad, you get a 5-level fusion. And these are the patients that they don't do very well. But you got to understand this. In this situation, you're not really trying to cure the pain. You're not trying to give them a brand new back. You're trying to manage the pain throughout these patients' lifetime. And the patient needs to understand that it's unrealistic to get the brand new back. We're going to do this to you. We're going to fuse your back just for you to get some sleep, just for you to get, instead of like 4 Norcos a day, take 2 Norcos a day. We're not trying to fix you so you can go back to your yoga or this and that. And this is the conversation that I have with the patient, except that I take that time and I go over all of these with my patients. Some surgeons, I don't know, I don't want to say that, maybe they don't have that conversation. So when the patient comes out on the other end and they have all these problems, they are truly devastated because maybe they thought that they're going to get back to their normal routine. Mm. So the knowledge of the patient before the surgery is everything.
Presumably, sorry to cut in. Presumably, you can't take
Sure.
this equipment out of the spine once it's in there.
No, now you can take the equipment out, but once you fuse one area, that's a one-way road. Once you fuse 2 levels, once you fuse that area, you're done. You can't go back and open them up or so. So that's the general thing. Of course, people will listen to the podcast and say, well, I know this. Of course, there's so many exceptions, but I'm talking about general rule that, that's what's happening.
For sure. And, I want to start moving into this topic of sort of corruption and conflicts of interest within the industry that I know your book touches on a lot. And, I recommend anyone listening to have a read of it because it kind of epitomizes what many people see as the issue with specialized medicine and with mainstream sort of scientific viewpoints, whereby it has sort of an aura of big pharmaceutical interests driving product sales and medications that are not in the patient's best interest. So could you give us a quick, it doesn't have to be quick at all, could you give us a rundown on what you've kind of discovered in your world?
Sure. Before I start, I want to say that if you can think about the worst controversial thing that you've ever heard, this is 10 times worse. Conspiracy theory or something, this is 10 times worse. And I'll explain it to you. Right. So what happens is that when you start doing these fusions in 1970s and 80s, what happens is that we would just put some bone between the 2 bones, and we were hoping that these bones will turn into a solid bone. Well, it didn't happen in about 25% of the patients. So 3 out of 4 patients, they did heal it and they were good, but 1 out of 4 patients did not heal it. We ended up with what we call non-union. Well, in those situations, pain came back even worse. So what we needed some way to increase this percentage, increase the percentage of number of people who get the fusion surgery to fuse and heal the fusion, heal the surgery. Right around 1985, a couple of French surgeons figured out a way to insert a large screw from back to the front, one on each side, into the vertebrae. They figured out that they can put these screw in, and each screw has a tulip that's attached on the other end. So when you put these screws in,
this is the pedicle screw that you're showing us now. Can you describe it?
So it's a very large screw that has a tulip that moves, that can accept a rod. So what you do, and it gets inserted from back to front and one on each side of the canal, basically, in through a bone structure we call a pedicle. Therefore, we call it pedicle screw. So let's say you want to fuse 4 vertebrae, you put 4 screws on each side, and then you connect these 4 screws with a single rod, and you basically screw them together. So this was a way to immobilize the spine so the fusion, so the bones can heal together. Well, as I said, spine surgery is a subspecialty of orthopedic surgery. We had learned in orthopedic surgery to heal the fractures. The best way of doing that is to hold them together so the bones can heal together. And we had this technique called AO spine, which is basically a rigid fixation. So you put the bones together and you put a plate with screws on each side to hold the bone together in a rigid fashion. We knew that that was the key. So when these screws came out, we were like, we've been waiting for this. Let's start doing them. So starting in 1985, we started using these screws as an adjunct to fusion surgery. So there are 2 separate things going on. One is the fusion surgery, which is basically putting bone graft between the 2 vertebrae and then augmented with these screws to make it heal better or faster. Well, when we first started doing these, there were really bad results. And there were about, at some point, 7,000 lawsuits against the manufacturer, a company called Medtronic. As a matter of fact, the lawyers not only sued the manufacturer, they sued the doctors too. There were about 500 lawsuits against North American Spine Society and American Academy of Orthopedic Surgeons.
What was going wrong with the screw? Why were people suing?
They were cutting out. The results were not good. People were not happy. Bad results, basically. So right around this time, when there were these lawsuits going on, an surgeon named Dr. Zadeblik published a paper that said these screws work beautifully. They are perfect. And that paper got published in 1993. So from 1993 on, he gave us the green light to use these screws. And by 1996, these lawsuits were disappearing for lack of evidence. And then by 2000s, when I started my practice, by 2002, these screws have become a standard of care to this day. So to this day, every time we do a fusion surgery, we put these screws in. Well, here comes me right around 2010, 2011, when I was entering the second part of my practice. The first part of my practice, I've been in practice for 20 years. The first 10 years, I did exactly what they taught me in my training. I basically went to these conferences and I did exactly what I was told. Starting the second part of my practice, I started asking questions because I started seeing results that they were not good. I sometimes tell people, I say, sometimes you might have something in your life that you're not happy that this happened, and it turns out to be the best thing ever happened. So when I was looking for a job in 2002, nobody was hiring in San Francisco or Sacramento. So I got a job in a small town north of Sacramento called Yuba City. And when I got that job in a small town of like 30,000 people, I was kind of not happy because I came from Boston and New York. But it turned out it was the best thing ever happened to me. Why? Because practicing in a small town gave me the chance to actually know my patients and follow my patients and learn what we were doing to these patients with these surgeries. That's why On the second part of my practice, I wasn't very happy with what we were doing. I started asking questions. What are we doing? What's going on? So it all started with me trying to invent a new device. We knew in the elderly population, of course, people were aging. In the elderly population, we have a serious problem with these screws. Why? Because the vertebrae, the backbone, is not a solid block of wood or concrete. It's like a shoebox. The outside shell is a cortical bone. It's a very dense bone, but the inside is what we call cancellous bone. It's a spongy bone, which with osteoporosis and aging gets really weak. So we would put these screws in these vertebrae and they would cut out like very easily, like a hot knife through butter.
When you say cut out, I'm just like, they would just fall out and then the person is left with screws like floating around in their body. And then,
well, what happens is like it would get loose. The most common way is that patient would not heal it, and you get an x-ray and patient is miserable with pain, and you see the halo around the screws. It would not just like cut out and fall out of the skin or anything like that.
And then once that's happened, then what can you do there? Can you do anything? Because presumably that's loosened up the whole bone around there. It's damaged the whole integrity of the spine.
Correct. So the treatment for that, as of today, is to go back and put a bigger screw. That's what we have. That's what we do.
Produced by the same company, presumably.
Right. Same thing. Just do it over, the same surgery over and over. Hopefully that every time you do, you put more bone, you put more stuff. Hopefully this time will get better. That's what we're doing. So anyway, I wanted to invent something that works better. So I came up with the invention. Actually, I invented a device that was a flat plate that sits against the lamina. Lamina is a cortical bone. So I wanted to use cortical bone as opposed to cancellous bone. So this device that I invented, and this is the device, it doesn't penetrate the bone. It sits against the lamina and uses composite straps. These straps are stronger than same size steel cable to wrap around the lamina, and they go through the hole at the base of this construct, and there's a clamp. So like a zip tie, you tie it and you turn the screw on top, and this clamps the strap. So basically this device holds onto the vertebrae without penetrating the bone.
Okay.
And my device, actually, I presented to Congress of Neurological Surgeons, and I won the Innovation Showcase in Congress of Neurological Surgeons. Thank you, in 2015. So while I was inventing this, I had some problems. I said, let me go back and see how they fix this, or this problem happens in the screw or not. And that's when I started really digging into the research and to the literature and see what was going on. And that's when I found that, oh my God, what is going on? And this is what I found out. After Dr. Zedeblik published his paper in 1993, 6 papers. Now, the paper that he published in 1993 was done by one person, him only, Dr. Zedeblik, one person, one study. After that, in late 1990s, 1997 to 2002, 6 prospective, randomized, multi-center, multinational papers came out, published in our own literature, Spine. We have a journal called Spine that's what we read. Published in the Spine that said these screws don't work. They do not increase fusion rate and they do not improve outcome for sure. So they do nothing basically. I was like, wait a minute, what is going on here? Let me dig a little bit more deeper into this. And let me figure out about Dr. Zedeblik. What is that study? And the first thing that I saw just dropped my jaw. That study that he published in 1993, it got published as a preliminary report. I spent about 2 years to look for the final report or follow-up report or what's going on. I couldn't find it. Eventually, I asked one of these older professors, I said, what's going on? He said, oh, that study was never finished. It was abandoned in the middle. I was like, say that again? If you Google Zedeblik spine fusion right now, if you Google Zedeblik spine fusion, you will see this article. You will see that it's a preliminary report. You will see that's been referenced in 1,120 articles as of today. This is the most referenced paper in the entire world of spine surgery. Everything that we do tracks back to that one paper. And it's a preliminary report. It's an unfinished report. Wait, when you think this is really bad, it got 10 times worse. Then, and what I'm saying is a public information. I got it from Google. Starting in so he publishes in 1993. In 1996, he starts getting paid from the Medtronic company as those lawsuits were disappearing. By 2004, he got paid $34 million from that company.
In direct payments or like?
Direct payments. They allege that these are based on something that he invented. And I've seen his inventions. I'm not impressed. It's nothing new that we already didn't have. So wait, you think that's bad? Wait, it gets 10 times worse. Then the same company, Medtronic, put him in charge of another study, very important product called BMP, bone morphogenic protein. It's a bone substitute. You know, earlier I said that in the fusion surgery, you open the area and you put some bone chips between the two vertebrae, hoping that will turn into a solid bone. Well, you have to get that bone from somewhere. And we had a problem because if you go get the bone from somewhere, well, now you have pain. You created pain now in that area that you got the bone from. So we wanted to get away from harvesting bone. So they came up with a product called bone morphogenic protein. There's a hormone that we all have. It when you break your bone, you excrete it, and that's how you heal the bone. They found it and they isolate it, and it comes as a product, as a sponge that you can use it instead of bone graft. So right around 2002, 2003, 2004, Medtronic put Dr. Zidebli in charge of that study. This time he got caught falsifying his results.
How did he get caught?
As a matter of fact, well, who found out about this? United States Senate.
Oh, wow.
Yes, it was an investigation by United States Senate. As a matter of fact, this is like in Wall Street Journal and stuff. This is not some conspiracy theory. United States Senate came to the conclusion that that paper in 2005 under his name was not written by Dr. Zidebli, was written by the company.
Is he disbarred or anything? Is he still working, or has any consequences been brought?
No, he's right now as we speak, he's the chairman of spine surgery in University of Wisconsin.
So it's the more corrupt you get, the higher you rise, I think.
Wait, it gets worse. I mean, just every time you think like, man, this is really bad. Just when you think that it cannot get worse, it got 10 times worse. Now, Dr. Zidebli was the chief editor of a major spine journal from 2002 all the way till 2019, I believe. I don't know the exact dates. This is like, there's never been in the whole history of medicine, a company has such a direct access into the literature. I mean, this is just beyond belief. Well, you know what? Now, here comes the interesting part. I had to come up with an answer. I mean, I was like, wait a minute, are we duped into this thing by big companies? Are we like lost our souls? Is everybody in it? What is going on? Are we crooks? Are we selling snake oil? What is going on? And it took me 3 years to come up with the answer. And this is after reading lots of papers, talking to lots of professors. I mean, these professors know me now. I of course, the biggest question the patients ask, probably people will ask me, is like, well, have you brought this up with your superior? Have you brought this up with the leaders of the? Absolutely, I have. I have ambushed them. I have followed them. They have cussed me out. Every time I question these screws, they want to just kill me. And I had to come up with this, it doesn't make sense. It's like, it's beyond logic. Why are they so sold out on this screw? I mean, as a scientist, I always assumed that I could be wrong. If there's a concern about something, I have to address that. I cannot just sweep it under the rug. So I had to say, what is going on? And I think I eventually found the answer. And this is how it goes. We train 5 years to become orthopedic surgeons. In this 5 years, our exposure to spine surgery is extremely low. The main part of the training is fracture fixation. We take call, we cover emergency room, and fracture fixation, fracture fixation, fracture fixation. And in that 5 years, they hammer it into your head that the key to bone healing is a rigid fixation. So after that 5 years, you do 1 year in spine surgery fellowship, 1 year, that's it, 1 year. And then you go out and practice as a spine surgeon. So what we did, we got our knowledge from orthopedic surgery and we applied that knowledge to spine surgery to do what we treat the spine in a way that we had learned from orthopedic surgery. Well, I've come to the conclusion that that is completely wrong. Spine surgery was never meant to be a subspecialty of orthopedic surgery, and I'll explain it to you. Concept of rigid fixation works in extremity, like arms and legs, for one important reason. Because if you have a construct that's not very strong, you can eliminate gravity. You can protect your construct. In the arm, of course, you can put them in a sling. In the leg, you can put them in a cast and put them on crutches so they don't put weight on it. In spine, you can't eliminate gravity. The second the patient gets up, that construct is under tremendous amount of stress. So you cannot. So the concept of rigid fixation doesn't work for spinal fixation. The very good example of it is when you build high rises in an earthquake zone. When you build high rises in the earthquake zone, you don't make them stiff, you make them flexible. So when the earthquake comes in, they put them on rollers, they can shake and dissipate that energy. That's the concept that we have to apply to spinal instrumentation. We have to have a device that I call it reactive rigid fixation. It's not a flexible fixation, but it's a reactive. So it can give and it can dissipate the energy and it doesn't cut out and be all pull out and be all failed and everything. That's the thing. So basically, we've been trained wrong. Spine surgery was never meant to be a subspecialty of orthopedic surgery. We have to go back to the basics and change the training from the beginning.
So you don't think this is like your superior? Sorry, I've got a Mexican lorry driving past. You don't think this is part of your superiors or other people in the industry who just know not to kick the hornet's nest and they want to leave sleeping dogs lie and they go, all right, we know there might not be something right here, but we just don't want to touch it.
But that's true. That I think so too. There are a lot of doctors that they think like me. They are very concerned because we do these. This is the situation. There are different surgeons have different type of practice. I remember I wanted to put an office in. I don't want to say the name. Let's say Reno. Reno, Nevada. I went there and I got to know some of the patients. Some of these patients. Now I'm not talking about all the surgeons there, but there were a couple of surgeons. The patients telling me, if you put my surgeon in a lineup, I cannot tell you who he is because I never met him. I saw a PA before the surgery. I met him 5 minutes before the surgery. After the surgery, I never saw him. So a lot of surgeons, they use PAs, to manage their, practice. And but in my practice, there's no PA. It's always me. I take the sutures out. I ran them on this hospital. Why? Because the more contact you have patients, the more you learn, the more you realize what the surgery is doing to your patients. So there are different type of practice. There are different doctors with different understandings of things. But let me tell you this: I am the first person, because I was inventing that other device. I found out about this, and I'm able to explain what is going on. When there was the investigation by United States, there's been 2 investigations by United States Senate in 1995 and 2005. And they said, yeah, there's something going on. There's something bad going on, but we don't know really what's going on. So I'm the first person that explains, I know what's going on. We got it all wrong from the beginning.
Even if, isn't it more concerning that, or the way I'd say it's very concerning is even if you have the sort of, you may well argue that having spinal surgery being built on baseline orthopedics that are focused on rigidity of the bone, and that doesn't feed in well to spinal surgery. But I see more the problem is deliberate obfuscation of the results and deliberate continued use by Medtronic of this screw, rather than like, I mean, the whole spinal surgery being education piece is a piece, but it's like there's someone in the boardrooms of Medtronic going, this screw's making us money, let's keep making money.
Oh, absolutely. Like making money as opposed to making no money, of course. It's like, but that's absolutely. I mean, it's
Do you know
just
how much they make?
crazy that level. Billions, I think they make like a few billions a year.
And how,
But that's a you can Google it. I know the number. I have, if you Google it, what's the Medtronic intake?
yeah.
That's public knowledge.
How much does a screw cost?
The screw used to cost about $1,000 per screw.
Per
Now I
screw?
think, yes, yes. And
That seems high, obviously. I mean,
well, let me explain to you something. Well, a couple of things. It used to be 1,000. Now, probably with the healthcare reform and all that stuff, it's come down to about 600 or so. But there's a reason for that. Everything that goes inside the patient, there's a severe price tag attached to it. Why? Because if something goes bad and you get litigated, you're going to pay up big.
mm,
So,
mm,
so you're not going to get charged like 40 cents for a screw. You're not going to get charged $5 for a screw. Anything that gets implanted in somebody is going to be super expensive because
interesting.
of that, because of the side effect. If it, oh my God, are you kidding me? If you want to get like a product and you want to insure it, you know how expensive an implantable device would be? That's just
Okay.
crazy.
Because they know there's going to be blowback. Something's going to go wrong somewhere.
Correct, correct. But in terms of when it comes to screw, the profit margin is so high
Mm,
that
yeah.
that it's completely worth it. And hey, if you have some guy write a paper that it works, you're golden.
I just Googled Medtronic revenue for the 12 months ending January 31st. This is just revenue, not profit, but it's nearly $31 billion.
Wow.
So they're doing all
Isn't
right.
that amazing? Right,
Yeah.
right, right.
Have
Now,
you had anyone come after you, or any blowback from them, or any emails telling you to shut up, or anything in between?
people don't know about this. My book came out, Corporate Spine, about 4 months ago, and I don't think the big
Am I in
boys.
danger?
Right. My wife didn't want me to write this book. My wife said, you have a good practice, we have a good life, you're going to ruin it. And once I found this out, I couldn't live with myself. I told my wife, I said, I can't sleep at nights. I can't live with myself when I find this out. Let me explain, and let me tell you this. I didn't just say, hey, I'm going to write a book. I thought about this for 4 years. Shall I write this book or not? Even to this day, I keep asking myself, am I doing the right thing? Because why? Because in 1990s, world of spine surgery went through a severe trauma because of these screws. So I'm telling myself, am I doing the right thing, or am I just steering something for no reason? And it always comes down to this. I tell people, I said, if I'm wrong and these screws are working perfectly, so what? There's been some, argument, and then eventually I'll go away and shut up and I'll go away and stuff. Everything is good. But if I'm right, can you imagine what we've done to our patients for the last 3 decades? What we've done to healthcare? It is
Terrible.
incredible.
Yeah.
And let me tell you this, and that's what the research says. I am not saying that I'm right, or let me tell you a funny story. This story happened to me. It's not like I heard from, this is my story. So, as I said, I'm not a keyboard warrior. I don't just write a book and stuff. I go to these conferences and I get up and I talk about these. So it was 2016. I was in North American Spine Society in Boston. So at that time, I didn't know what I know now. I was just starting to ask questions. So I got up in front of 1,000 spine surgeons and I said, how is that six independent, multinational, multi-center papers came out and said these screws don't work and we're still using it? Well, and I didn't want to get in fight because these are very powerful, famous surgeons were on the panel. So one of the doctors said, well, we did our own studies later and we found out that they worked really well. And I didn't want to fight them. I didn't say, well, why didn't you publish those? So I sat down. About 20 minutes later, it was a break. I was getting coffee. I was talking to a representative from one of the companies. I was just talking. And he introduced me to a surgeon behind me, a very famous surgeon from San Francisco area. And he said, Dr. Aslie doesn't like the screws. And he turned around to me and he said, oh, you're the gentleman that made that comment about the screws. Well, I want to tell you that you're welcome to your opinion, but you're very wrong. I said, it's not about me. It's not about me that I'm right or wrong. It's about research. The research says that these stuff don't work. Maybe, just maybe they're trying to tell us something. He said, I know. I published those papers. Those are my patients. I said, yeah, what's your name? He told me his name, and I had the papers in my hand. He was right. He was the author. He was the fifth author of the second paper. He said, see, that's me. That's me. I'm like, okay, well, let's read your paper. At the end, the last sentence said, based on our current knowledge, we do not recommend routine use of pedicle screws. He looked at it again. He said, no, that's wrong. And he walked away.
What? So what's going on there?
I swear to you, that's exactly how it happened. He didn't read his own book. I mean, he was the fifth author. He did all the paper, but the first author probably wrote all that stuff. And I don't know. That's what I'm dealing with.
So this has been quiet since the last sort of Senate committee stuff in 2005, you said. This has been quiet
Correct.
Since then.
Yes.
So
yes.
What's been bubbling along in the meantime, even after that Senate committee, no one decided to continue to investigate? You're the only guy who's like putting his head above the parapet here.
I'm the only guy. And the only reason I found this out because I was developing the other device. And that other device made me come back and ask more questions about this. And that's when I found out, oh my God, you want to know something even worse? In 2018, now I talked to one of the professors and he said, oh, these papers are old. I'm like, there's no expression date on these studies. I said, no, they're old. And then it was 2018. So 2018, I walked into my office one of these, came back from that conference. And in Spine Journal, there was a new study in 2018. And that study said the exact same thing, that addition of these screws did not improve outcome. I was like, oh my God. So we have like 3 decades of information. They're all saying these screws don't work. We're still doing this. It's crazy. So anyways, back to that decision that you said, to writing the book or not writing the book. Shall I do this or shall I not? Am I doing the right thing or not? It always comes down to the same thing. There was a problem in 1990s and we didn't solve it. We just put it under the carpet. The problem didn't go away. We just put it under the rug. So we have to go back to our basics and we have to fix this as a specialty. So the spine surgery would be a specialty and not run it like a cult. It's like being run like a cult now. All these leaders of the field, the professors at like Johns Hopkins, Harvard and stuff, they all belong to these societies.
Is that because you think once the emperor realizes he has no clothes, or the people start saying, hang on, that it really doesn't work. We all know it doesn't work, but now we really are saying that it doesn't work. Is that because there'd be so much loss of face for these guys who have done this surgery thousands of times and, supposedly inflicted this on thousands of people?
Well, I mean, it goes beyond that. Now, don't get me wrong. I don't want to incriminate a lot of the surgeons. A lot of the surgeons, 80% of the surgeons are on my side and they're sweethearts. The problem is that the leader, that top echelon with what I'm saying, I'm cutting off the hands that are feeding them. So they are sold out on that thing. And that's one of the parts that I say in my book, that it's fashion, it's chic in the world of spine surgery to say that you're a consultant for a company. That's how you're being gauged as a successful or not. The problem is that once you become a consultant, you're supposed to evaluate the products of that company on an unbiased fashion, but they end up not doing. They write favorable papers, and then 10 years later, we find that those products, some of the products didn't work, and nobody raises a question. Nobody says, wait a minute, what happened here? And the way I explain it is that the true people who got hurt, victims, are not just the people who got that device. It's much broader, because every time you have a useless device, the entire world of spine surgery goes in the wrong direction. The whole what is that? The whole direction changes. So there should be some sort of accountability. This has gone way too long, and we have to have evidence. And it's very simple. When I explain this to some of my friends, they're like, well, that's basic physics. That's like second grade physics. I'm like, exactly. But after I deciphered it, see, before I decipher all of this, it was like, what is the answer? After I deciphered it, I'm like, oh my God, it's so simple. Let me explain it to you. The motion of the vertebrae is a rotational motion. The vertebrae doesn't slide back and forth, doesn't slide up and down. It rotates relative to a bone below it, right? That's very simple. Well, guess what? When we put the screw into the vertebral body, screw has to stop toggle, not pull out. Well, screw is not a device to stop toggle. Not only that, you give the screw nothing but a spongy bone. So you tell the screw to do something that's not made for. Two, you give them nothing but spongy bone. When the papers come back and said it doesn't work, you don't want to listen to it. It's beyond belief.
How many of these surgeries are being done every year? Do you know?
500,000, hundreds of thousands. Yeah, wow. That statistic is very obvious. But you got to understand, it's not the United States anymore. Whatever we do, the rest of the world copies it. So this is the accepted treatments for the entire world. We not only failed America, we failed the entire world. I mean, that's just bad.
And then it's going to have terrible repercussions when it's found out, because everyone's going to go, I'm not having a spinal surgery.
But we have to, and trust me, I've asked that question to myself many times. I've asked my questions for years, but same answer comes back, that we have to fix it. We have to go through the pain and fix it. That's the only way we can fix this. As painful as it's going to be, that's the only way we can fix it and move forward. Because right now we're in a dead end. You tell the spine surgeons, they're going to say that the screw as good as it's going to get. Why? Because it's been hammered into their head in orthopedic surgery that the answer to any problem is a screw. And there's no changing it. It's been hammered into their head. I am one of them. And so that's why I understand the concept, so we need to change that. Whoever wants to go to spine surgery, they have to unlearn what they learned in orthopedic surgery, and they relearn. It's like using quantum physics as opposed to Newtonian physics. If you want to build a building, you can use Newtonian physics. But if you want to shoot an aircraft to the moon, to the space, you got to use quantum physics.
What the kickback is going to be, or the pushback is going to be on you, is that, Dr. Aslie just wants to sell his own device.
Absolutely. And I explained that in my book, that I got, somebody told me that. And that's why I stopped developing my device, because the problem got too big. when the problem, initially when I started all of this, I wanted to invent a device and get famous, and not famous, but rich, and have a good life, have a nice vacation home.
Ditto.
But the problem got so big that at this time it's beyond me. It's beyond me getting a nice car or a nice house. We're talking about an entire specialty now. That's why I gave up on I stopped developing my device, because we have to fix this first.
Sorry, go on.
Yeah, and the other thing that I tell people is that for that comment that actually you made, my point is this: I am not saying anything. All I'm saying, listen to the research. If you're not going to listen to research, why do we do research? I mean, all I'm saying, listen to the research. And I wanted to show you something. There was an article in 2020 in journal. I walked into my office one day in 2020. The lead article, this is exactly what the lead article said. Undisclosed conflict of interest is prevalent in spine literature. Undisclosed conflict of interest is prevalent in spine literature. This is our spine journal telling us that our data, our literature is tainted. This can't go on like this. This has to stop.
It feels like it's everywhere. It feels like it's everywhere in big business and big pharma, skewing research and big medcare, skewing research in order to get the results. You tell the company what results we want to have, and then they'll provide it.
Correct. And I explained this to a lot of, this is not the first conversation I'm having. I've said this to many of the people that I know and think about the conflict of my device and this thing. And they're saying, you know what? If you have a device that you think works better and we have evidence that this thing doesn't work, then more power to you. I mean, if you have a solution, if somebody comes in and says, hey, we got a problem and don't have a solution, then what are you going to do? But as I said, I'm willing to give up whatever the proceeds from my invention, because as I said, this problem is too big. I really don't care about that part anymore.
Why don't you
have to fix this.
You could keep making it and then sell it to Medtronic.
I'm not, I stopped that. I'm not even worrying about it. I just want to, people ask me, well, what do you want? This is what I want. This is what I think would be a successful thing. Spine surgery needs to become a specialty by itself. Spine surgery is too complex to be a subspecialty of orthopedics. Orthopedic surgery is very simple carpentry. Spine surgery is not. We're talking about much more complex stuff. So that's one thing. Two, I want to change the absolute attitude among surgeons. We have to listen to our patients. We got to follow our patients. We got to have an understanding of what we are doing to our patients. It's not just somebody, hey, you got two level badness, you get 2-level fusion, 3-level bad, you get 3-level fusion. That is we're not gonna have any progress. We have to come together as a collective and try to figure out how we can minimize our surgeries and try to figure out where this pain is coming from. Try to refine the field of spine surgery.
Yeah, it's very difficult when you obviously have very strong conflicts of interest and very strong entwined agendas that will push back, and they'll push back very hard on that. There'll be many people who'll be making millions now and billions who just don't want that information to come out and will muddy the water as much as possible.
Right. And one of my spine surgeon friends said, "You're going to get assassinated."
Yeah, I mean, I'd watch out. I would make sure your doors are locked.
I've thought about that too. I really have. And as I said, at this point, the problem is so big that it's not about me anymore. It's about a specialty of medicine.
Yeah, I think you're doing the right thing. I mean, I think you're doing the ethical thing. If you believe something is not correct for people and it's causing a lot of harm, I mean, what's the premise? First, do no harm in modern medicine. and this is clearly something that's going to cause harm, or at least not make the problem better if it's going to give people more pain. So what option do you have?
It goes even beyond. I tell people that maybe just, you got to understand, we might use, let's say my device gets approved and we use it. We might find out my device doesn't work very well. We might come back to the screws, but then we have to realize what we have. We can't just say that, oh, this is the best we got. We put it inside the patient. When the problem comes back, we blame the patient. We say, oh, he or she didn't follow our instructions, therefore this. No, we got to realize that our fixation is not the best. So when the patient comes back, we got to be more vigilant in terms of what is going on, as opposed to sending the patient to pain management for the rest of their lives.
Where do you see this in the next 5 years? Do you think you'll make more ground, or?
At this point, I really don't see anything. I got to do what I have to do. I can tell you one thing, I'm not going to stop. That's one thing I can do. I can't tell you where it's going to be, but I can tell you where I'm going to be.
Okay, Dr. Aslie, look, it's been fascinating. I've loved talking to you. I want to hear more, but I think the best thing is you tell people where they can find more information about you and about your book.
Sure. My book, Corporate Spine, you can get it from Amazon. It's only $25. You can
Amazing.
say Corporate Spine. Yes. And that's about it. I have a website that I haven't set up yet called corporatespinebook.com. And I've actually made videos about every chapter. So if somebody reads the chapter, they don't understand, or they don't want to read the book, or they don't have time, they can watch those videos, and I explain what's in each chapter, called corporatespinebook.com.
Love it. Get it on YouTube as well. Get a YouTube account called Corporate Spine. Everyone's on there, and you'll be able to and I'll send a few links to people in the show notes and everything. And Dr. Aslie, well, I hope you're still alive and kicking in a few years. We'll have you back on the show.
Yeah, thank you very much.